All right. Well, I'm excited to train you guys on this. We've had a lot of really good feedback from the other clinics that are live, and I think it's a really good tool for certain patients. So why don't we get started? So welcome everyone. I think I know all of you, but my name is Crystal Wong. I'm a family doctor. I practice at Ravenna. I've been with UWPC since 2011, and prior to that did my residency here at UW. So I've been here at UW for 16 years now. It's kind of crazy. I know, Pam, collecting the years, actually we don't get those pins of service because we're not like hospital employees, but collecting all the doodads from being here a long time. So today we're going to talk about continuous glucose monitoring, which is a specific type of remote patient monitoring. I know you guys were a site of our hypertension pilot, and if I have a little time at the end, I can talk to you guys about some of the new things on the horizon about hypertension management. But today we're going to talk specifically about glucose monitoring for patients with diabetes. You guys have an incredibly tech-savvy population at Factoria, so I'm sure all of you guys have been kind of inundated with patients who use different gadgets and devices and want to send you all sorts of things. So I think you'll relate to this topic today. So in general, RPM is use of a medical device to track biometric data and send to the care team for analysis and use to augment their care plans. You know, we're using a lot of devices for chronic disease management, and you know, these are still fairly new technologies, but we're hoping that this will offer us an opportunity to improve our access for patients that truly do need the face-to-face. It also provides new areas of revenue for members of the team that previously were not typically revenue generating, like nurses and RDs. And thus, you know, help us kind of move more into a team-based model. I think that's one thing you'll notice as we go through the ins and outs of this program is it truly is team-based, and you'll be getting excellent support from your nutritionist here. So today what we're going to go through is the basic workflow, and we worked really hard to try to make this workflow kind of sync with our typical clinical workflows. So hopefully it doesn't feel too foreign. We'll talk about patient identifiers, so what makes a good patient. We'll talk about what it takes to enroll the patient. We'll talk a bit about what's going to happen behind the scenes for your team to help support RPM, including how your RD is going to get the data to you. We'll spend a little bit of time about interpretation of CGM reports and how to facilitate care, you know, once you decide you're going to change things, and we'll touch on the coding and billing for this. And also, you know, please interrupt or type in the chat, you know, if you have questions. You know, this is meant to be really a dialogue, and hopefully we have some time left over for questions at the end as well. Mika will be watching the chat. So this is a video of the whole workflow. I don't expect you to look at this and memorize it or whatnot. This is, you know, was more an exercise for the team that helped build out this program. But I think the main points that I want to emphasize to everyone is that this is truly a team-based process, a team-based program. And you can see the individual swim lanes on the left there. We've got your panel navigator, we have the provider, we have the patient, and we have you know, your clinical support team, like your MA, your RN, your RD. And there's steps in the process that are going to be, you know, partnered together to get patients to you know, hopefully their goal of better diabetic care. So we're going to focus in on the provider swim lane, obviously. But one area that I want to highlight is this area right here that I'm kind of hovering my cursor around. And this is about insurance coverage. We ran a pilot prior to, you know, designing this formal program at Ravenna, Issaquah, and Woodinville. And I'd say this was probably the biggest area that needed a little tweaking, needed a little bit of work and support. So I'll be going through, you know, what we were able to build out today to make sure that this insurance coverage is as least confusing as we can make it. Okay, so the first thing we're going to talk about is medical eligibility, meaning what makes a good patient. Not what makes a patient that will get this covered by their insurance, but who is included in this program. Our program is really going to focus only on type 2 diabetes. I know that all of you take care of patients with type 1 diabetes. So, I have several on my panel that for whatever reason, they don't want to see an endocrinologist. You can think about using this for them, but don't enroll them into this full formal program because, as I mentioned, it's team-based. We're doing a lot of standard training with the RNs and the RDs that are participating in this program, and it'll be difficult for them to have to deviate from that for people with type 1 diabetes. So, if you decide to do that for a patient with type 1 diabetes, you'll have to kind of, figure that out yourself, not for this program. I think there's kind of this misinformation that CGM is really only for if you have insulin. And it's true that this can be a big win for someone who is supposed to be, doing chem sticks but doesn't like poking their finger. So it's true that, that's a natural fit, but you don't have to be on insulin to be in this program. CGM for patients with type 2 diabetes is really about engagement in chronic disease management and patient engagement in their care. So if you have someone who is either having fluctuations in blood sugar, patients who are really interested in tailoring their lifestyle, they're thinking about turning over a new leaf, starting an exercise program, changing their diet, et cetera, and really want some real-time feedback, this is a really great tool for them. You don't have to just be on insulin. We already talked about how we're going to be excluding type 1 diabetes, but there are a few other groups that we're going to exclude from this program. One is any patient who's getting care from an endocrinologist. And I know all of us have some patients with type 2 who see, endocrinology with us at DCC or outside the system. And the reason why we decided to exclude them is the codes that your team is going to build and the codes that you will build to interpret the CGM report is time-based and can only be billed once a month total for this patient. So if you were to have endocrinology billing this and you billing this, it'd get real confusing real fast. Charges would probably get dropped, patient may get, double charged, et cetera. So we didn't want to do that. So basically, if your patient is seeing endocrinology and is interested in this, please have them talk to their endocrinologist. This really is standard of care for endocrinology taking care of diabetes. In fact, our DCC here at UW bills out almost $400,000 of CGM charges a month. So they're very, very heavily use this, and it's very, very commonplace. We're also excluding pediatrics and gestational diabetes for the time being for, I think kind of obvious reasons. We're going to start kind of simple. That on the side, that picture of a cat, that cat is wearing a Libre sensor, which is what this program uses. And that's actually Erin Beckstrom, the SLU manager's cat. Her vet prescribed it for peanut butter because he was acting lethargic, and it turns out peanut butter has diabetes. So even vets are using it these days. I would also just call out to please partner with your care management team. Your panel navigator is working real hard on your diabetes metrics, and this is a great tool potentially for someone who's not meeting diabetes goals. So, when you're doing your care management meetings, running your diabetes, gap lists, consider using this program. Okay, well, before I start talking about the sticky situation that's insurance coverage, does anyone have questions about medical eligibility or good fit for patients? All right, let's talk about insurance then. So, I'm hoping that the insurance landscape will get easier with time. That typically is what happens, it's what happens with new drugs, et cetera. But right now we're living in kind of a sticky quagmire. So commercial insurance in general covers CGM, both the equipment and the program, very well for anyone with a diagnosis of diabetes. Doesn't matter if your A1C is 6.9 or 12, you know, it'll be covered via commercial. They also cover it, you know, it doesn't matter what types of meds you are, you could totally just be lifestyle controlled, they'll cover it. Now, you know, everything comes with a grain of salt, right? You know, you may have some patients who have high deductible plans, in which case, you know, the insurance says, oh, it's covered, but lo and behold, they go pick it up at their pharmacy and it's super expensive. We're going to talk a little bit about cash paying for this because there's some tricks to getting this affordable for patients, but just know that we've had a couple of reports of that happening. For Medicare, there's an added layer of you know, requirements. For Medicare to get the device covered, the patient needs to be using insulin TID or greater. So if you had a patient that's just on basal Lantus and doesn't need prandial insulin, they actually wouldn't meet criteria from Medicare to cover their device. Additionally, there's this kind of arbitrary, quote unquote, needs frequent insulin adjustments. That's more of just something to write in your chart thing as opposed to anything that's really quantifiable. And then Medicaid actually, in addition to needing at least TID insulin, needing, quote, frequent insulin adjustments, unquote, also needs to have you recommend that the patient be checking their blood sugar at least QID. Doesn't mean the patient is checking at QID, but the recommendation from you has to be that they check that frequently. So obviously there are a lot of hoops to jump through. In the next few slides, we'll talk about how to order these and a little bit of the background, but this is kind of current state. Hopefully we can kind of get rid of some of these X's in the future, but it is what it is right now. I'm going to spend some time talking about some standard Epic dot phrases that we were able to create for this program, and all of them have language in it that would meet criteria for documenting these things if your patient has one of these insurers, and we're going to need to go through a prior authorization process for them. So just know that we built in some language in there so you don't have to make it up yourself or remember these things. So that being said, obviously it can be quite hard to get this covered for certain groups of your patients. There are ways around it. So first of all, Libre often has coupons. In fact, I had a patient the other day with type 2 diabetes on oral meds who has Medicaid. So she was not going to be able to get this covered, but she was able to get a coupon from Libre, and so she got 2 free sensors, and that's a month worth of profiling. And for her, you know, that's all she really wanted. She just wanted to see how, you know, her blood sugar was responding to her taking her meds. She wanted to see if there was any patterns after meals. And she was, you know, committed to exercising again. She wanted to see if she could stabilize her blood sugar. So, you know, 1 month of free sensors was great for her. That's all she wanted. You know, she said that she would think about paying cash for them if, you know, she wanted more data, but, you know, she was pretty happy. She just got 2 free ones. Additionally, you can have the pharmacists at the pharmacies run their prescriptions not through their own insurance, but through GoodRx. And oftentimes they'll have a cheaper cost, even cheaper than if their insurance does cover it. And you can actually use the GoodRx website to find a cash pricing. I think all of us know this trick by now and tell our patients to kind of shop around, but you can get 2 sensors for as low as $70. I think that's the lowest we've ever seen them, so $35 each. So, you know, a lot of patients will be willing to pay cash, you know, to be able to get this really good data. I do want to mention that the RPM codes, meaning what your RD is going to bill out to, you know, bill for their time, have been well covered by all payers, commercial, Medicare, Medicaid. In fact, when you guys did the hypertension pilot, you know, we got 0 denials from insurers, and we had patients from all types of payers included in that group. So Anyways, you don't really have to worry about the RPM codes so much, but it's just really the device is the complicated part here. Okay, so let's talk through kind of step by step what's going to happen if you were to find a patient that you think would be a good fit. So typically this is going to happen in a patient care visit, whether that's face-to-face or telemedicine. You know, you are doing follow-up for a patient that you just got, you know, their diabetes screening back and they have newly diagnosed type 2 diabetes, or you're doing routine follow-up with one of your patients who has diabetes and you're talking about how to, you know, get them under control or whatnot. So you bring this up, you talk about the program, the patient says, yes, I'd like to do that. There are a couple of things we'd like you to document. This is very similar to, you know, the BHIP process. So there is a written consent or a electronic consent that comes through the chart that you'll put in this .rpm consent to stamp in the chart that you consent to the patient to this program. They understand that it's billed to their insurance, et cetera. So there's that one. And then after you consent the patient, you can refer them to the program by using the referral to RPM. And you'll order that just like ordering a referral to cardiology, referral to dermatology, et cetera. Same place in the order entry. And then that's going to route to the pool that your RD is going to work. And that's how they're going to know that you, you know, have a patient for them. There's also a dot phrase that you can use, the .cgm RPM enroll AVS. This has some really patient-friendly language about what this program is about, what to expect next. It also has some coverage language, like I believe it's medically, or this is medically necessary for your diabetes, and that will help out the prior auth team. If you put that in the chart, you know, if they have to go and help get coverage for the equipment. You don't have to use that, but, you know, it is there. So you don't have to, you know, make up your own stuff about reminding the patient that you're enrolling them in this program, et cetera. And then please do CC your chart to your RD. She's going to help you guys with this program and do kind of the administrative work. So this is just another way for her to gather what your plan is for this patient, not just, you know, this person is coming, but, you know, my plan is, you know, we just started metformin. I want to see if this, how it looks on the CGM, or, you know, she doesn't want to start medicine right now. She's going to instate low carb diet and exercise, and then we're going to see it, et cetera. So just good communication. Once those things are done, you need to get the patient their actual equipment. And this is prescription only. You can't get it over the counter, so they do need a prescription from you. For commercial insurance and Medicaid, you actually just order it like a medication. So if you go into the orders tab and you just type Libre, it'll pop up and you can choose the sensors. And again, one sensor lasts 2 weeks. So 2 sensors is a 1 month supply. I would say for most patients, you're only going to be doing this short term. Maybe if you had a patient who was on insulin and they're like, wow, this sounds awesome. I would so much rather do this than poking my finger, and they're going to wear it continuously, you know, for eternity, then you can put in a 90-day supply for them. But, you know, for most patients, this is because, you know, you're changing something in their plan. They need it short term. And so typically I will just prescribe 2 sensors with a couple of refills on it. If your patient has Medicare and we need to go through the Medicare prior authorization workflow, you have to actually order it out of their DME benefit, because that's where this device would get paid out of. So, hey, Sarah, do you mind muting? Thank you. And you could do this a couple ways. You can use the DME form. You know, there's a DME form. Or alternatively, what I do in Epic is I still order it like a medication, but I switch it from normal to print. So it prints out and then I sign it and then I give it to the patient and I say, this needs to go to a DME company. Now, to be very confusing, there is a Medicare DME form you also have to put in. So the thing that you signed, that is your prescription that, you know, you're giving this to the patient. The Medicare DME form is what Medicare requires to get coverage for it. So There's a linked PDF that's in a dot phrase that I will show you for generic documentation of the CGM program. And if you can just remember to put the dot phrase into your Epic note, the hyperlink will be in there, and then you can just click it out of there and print it for the patient. Alternatively, if you want to print a few and have them kind of around clinic, that's also fine. But you do have to fill this out and sign it, and that does also need to go to the DME company. The last thing I want to mention is the way that the sensor works is the patient places it on their arm, and then they use typically their smartphone to sync it every 8 hours. If your patient doesn't have a smartphone, they're often going to need a prescription for a reader. And this is just like ordering like a blood glucose monitor. So when you type in Libre, they'll have the reader and actually have the orders here for you guys to see. So if you needed a reader, if you just type Libre, you pop up both of these orders. So there's the reader if the patient doesn't have a smartphone. And here's the sensor. Everyone's going to need this sensor order there. Okay, so what happens then after that? Okay, so your referral is signed, the consent is in, you ordered the patient the equipment, it goes to your care management work queue. So your RD is going to be working these and pulling them out of the queue. And the first thing they're going to do is they're going to check what's in the EHR. Is the consent in there? Obviously the referral's in there because they pulled it out of the referral queue. And did the PCP order the sensor/device if necessary? If all of those are a go, they're going to call the patient and say, hey, I'm calling from Factoria Clinic. I'd like to get you scheduled for your intake. Did you pick up your equipment? And the reason why they need to check that is the first visit, the code that they're going to use to bill out is for device setup and training of the patient. So one, the patient obviously has to have their equipment and bring to the appointment. And two, it actually has to be face-to-face. We are not, so the CMS regulations right now for this code is that it cannot be done via telemedicine or phone. So it has to be in person. So your RD will reach out and set up that in-person visit for the patient. Now, if when doing this, your RD notices like, oh, the provider forgot to order the sensor, then they'll just ping you with a message and ask you, can you please order this, et cetera, before we do that. All right. So this is just background. So when you have a patient who has Medicare or Medicaid and they need the prior auth process, the prescription authorization team is going to handle this for us. So the same people that help you with prescription prior auths. And they're going to make sure that, they have all the packet together of the DME form, the signed order from you, the documentation and the chart notes that meet criteria, and they'll help with that. And your RD is getting trained on how to kind of partner with this team and how to check in and see if there's any snafus. So I would say this is like one big win because it was a little bit of a black box if this happened during the pilot. Okay, so everything's a go. Your patient got their equipment. They're going to come in and do the intro meeting with, in your case, the RD. And the RD will do some basic teaching about the program. They're going to teach the patient how to use their equipment, including placing the sensor, syncing the device to it, setting up their account and leave review. And then they're going to try to squeeze in some medical history review, current lifestyle habit review, and also some goal setting. They may or may not be able to get to that. It typically depends on how digitally savvy this patient is. We've seen the whole gamut. We've seen patients show up like with their sensor on their arm already and everything set up. We've also had people that needed a little bit more hand holding. So, they'll tailor this to your patient. If your patient is having a lot of problems setting it up, they might set up a second visit to kind of make sure they get through the whole curriculum. And again, just a big plug for making sure that your RD knows what you want to do for the diabetes plan, so she can, teach the patient to the tailored plan. Once the patient is good to go and has had their intake, they're going to start transmitting data. So the sensor is meant to be worn continuously, and as I mentioned, it lasts 2 weeks. And then your RD will be checking into the Libre Review portal to download their reports. The minimum amount of time a report should cover is 14 days. Any less than that, and it's not really enough data to do anything about. So the earliest you would get a report from your RD would be 14 days after the patient started wearing it, okay? There is a standard dot phrase that the RD is going to use that also gives like a little mini summary of the report. So, you know, when you're in basket time and you get one of these, you don't have to drop everything and open up the PDF. So the dot phrase has the GMI, and we're going to talk about metrics in a little bit, but it'll have the GMI, the time and range, any hypos, and that will just be in the body of the text. So if you open it up and you say, oh, cool, GMI is 6.3, time and range is 99%, no hypos, then you know this person's doing really good. I can hang on to look at the actual report until this patient's going to come in and we talk through it together. You know, I don't have to look at it together today. You know, if you get a report and the GMI is like 11, you might want to click into that PDF and just eyeball it, you know, if you have the time. And then you'll get a message from your RD that the report's available in Epic. They will be housed in the media tab, which we all know is kind of like a graveyard of electronic files where they go to die. And it's very difficult to kind of track, you know, scan versus scan versus scan. So one thing that we did get added, there is a diabetes flow sheet, and it's called right here, diabetes MA note. If you type that into this little search with the magnifying glass and then star it, it'll always be there for you. And right in here, you'll see these rows that say GMI, time and range, and time below range. So this will trend it for you. So let's say you have someone who's going to do this for a couple months. You know, at the end of the couple months, if your RD is pulling every 14 days, you'll have you know, 4 GMIs and 4 time and ranges and time below ranges, and you can kind of trend them over time in one handy dandy location. All right, let me pause there and see if there's any questions about the workflow or what's going on before we jump into AGP report interpretation. Any questions about what you need to do to get someone enrolled?
This is Deb, Dr. Huang. I just wanted to make one correction. Hi, everybody. I didn't get it at the beginning of this. You have to gather the data. The sensor needs to be scanned at least every 8 hours, but the individual can scan much more often than that. So the sensor holds 8 hours worth of data.
Yep. We're going to go through a little bit of that in these next slides too, Deb. So, yeah. All right, cool. So why don't we jump into AGP reports? So I know it's hard to learn new things sometimes. This is the world. This is the way the world's going for diabetes care. I've only got a few minutes to go through this with you guys, but Savitha put together an awesome webinar, and the link will be sent out to you guys. It's also at the end of this presentation, where you can watch her real in-depth training on how to interpret these reports. There's also a link at the end of this presentation to the Abbott site. They have a really provider-friendly training that's only about 13 minutes. If you want a little bit more of like a pithy Q&A, you can watch the recording from the latest or the March lightning rounds. Savitha and I did it on CGM and just some caveats. But let me orient you to this report. So this is what's called an AGP report, or an ambulatory glucose profile. And this is what Deb is going to be downloading for you guys from the Libre Review account. And this is what's going to be scanned into the media tab in Epic. There are basically 3 areas to look at: the upper left, the upper right, and then down here, which is the ambulatory glucose profile, which is more like a waveform of you know, the readings over time, kind of like just a nicer way to interpret blood sugars compared to, you know, a little book with, you know, some points written in it for you to kind of connect the dots mentally in your mind. So let's dive in. Okay, so this is the upper right corner. You'll see it right here with the bar. And this is what's called time in range. And it divides into high ranges, goal ranges, and low ranges. And really the big thing you want to pay attention to is this green bar, which is called the target range, 70 to 180, and this is what we call the time in range. And the goal for patients is to have a time in range greater than 70% because it does correspond to an A1C of 7%. And that's, still the diabetes target. One thing I want to also mention is this does not take the place of checking A1Cs. It's similar to finger stick blood sugars. You use that to kind of analyze the micro, but the macro is you're still going to be, checking A1Cs on a, reliable frequency with these patients. And then these other ones are kind of self-explanatory, but time below range, this is kind of more important for patients who are on insulin, but your goal will be less than 4%. And then time above range, just, minimize the hyperglycemic episodes your patients are having. Okay, this part is, let me go back to the full report, this upper left-hand corner, and this gives you some information about how well the patient wore their sensors, as well as the big metric, which is the GMI. So let's break this down. So the first thing you're going to see is the time range in which this covered. So in this case, this is February 25th, 2021 to March 24th, 2021, and that's 28 days of data. To have a valid report that you can actually make changes on, you need at least 14 days of data. The next line is the percent CGM is active. So this means the percent of time that the patient was wearing their sensors and actually syncing it with their reader. If they wear it on their arm, but they forget to sync it, it's going to be 0. If they forget to put their sensor on, it's going to be 0. So, you want at least scanning at least 70% of the time, meaning 70% of the time their sensor's on and they've remembered to sync it. As Deb mentioned, the maximum time between syncs is 8 hours. If they go beyond that, they're going to lose their data. So, that's definitely a point that's stressed with the patient when they're trained how to use this device. They could obsessively scan it like every 5 minutes if they wanted to. I'm sure there are some patients that might do that. So now let's break it down into these metrics that you see right here. So there's an average glucose, but the more important metric that you're going to look at is this GMI, or glucose management indicator. And this is essentially a calculated A1C based on the patient's numbers in this report. So this is where, it gets really useful for a patient because, as A1C is a long-term metric. It takes, weeks and weeks to see any impact in that, whereas this is real-time feedback. So if the patient were to maintain this level of glycemic control for 3 months, their A1C would be 6.1 or 6.7. If you actually tested it, it might be like 8.2 or something. But, this gives the patient kind of an estimate of, how well they would be controlled if they just kept up the good work. The last variable right here, or the last metric, is with glucose variability. And this is more to just kind of help lessen the risk of hypoglycemia. Again, a little bit more pertinent to patients who are wearing this, who are on insulin, but goal is below 33%. And then here is just like a really simple rubric as we're all learning how to interpret these reports. So step 1, check and make sure there's enough data. So this is a valid report, 14 days or more. 2, and again, I mentioned this at the beginning of the presentation, really the power of CGM as a tool is patient engagement in their care. And so really the best practice is to sit down with the patient and look at this together. Help them identify, okay, when do you eat? When do you exercise? Or when are you at work? When do you go to sleep? When do you take your meds? And then look at the patterns in those, in the profile, those waveforms, what happens after those things. So for instance, I think I gave you this example earlier. I just used this for a patient with type 2 diabetes. She's actually pretty well controlled, but she wanted to see what was happening after meals, and she definitely was having an evening spike, in response to her dinner. So, she kind of, reassessed her diet a bit. So then you'll look for patterns, like, are there readings within target range? If not, what was the impetus for that? Are there any areas with hyperglycemia or hypoglycemia, and what triggered them? And then you'll make a plan based on those findings. Like, okay, maybe your dinner's a little too heavy. Do you think you can, decrease the carbs in that? Or maybe you eat a bigger lunch? Or, is it really dinner? Or are you snacking after dinner to, make a tailored plan And then there's a standard dot phrase, the .cgm RPM interpretation note, and that will allow you to document your interpretation of the AGP report. It also hits all the billing criteria, so you can bill your code. And then after you discuss this with the patient and you change the plan, make sure you let Deb know so she can help you, fill in the blanks in between your visits and, the hard work she's doing with the patient. We also have some other dot phrases to help with communication. So there is a RN follow-up visit note that Deb will be using to just kind of document some things, and also that's where the link to the AGP report will be housed. We already talked about the interpretation note. That's what you're going to use when you interpret the profile. There's the treatment AVS that you can use after any visit that you're going to change things for the patient based on their reports. And I think we're all kind of used to this back and forth in the in-basket, but that's how communication is going to happen. Obviously, you can always, catch Deb when she's around in person, or, message her or whatnot, but typically it'll be through the EHR. This is a grid that summarizes all the codes that will be used for this program. The main one that you need to focus on is this 95251, and that is the interpretation note. I think it might be the next slide. We actually have a toolkit that you guys can download or print out if you want all these resources at your fingertips, and this grid is in there. One caveat about this code is it can only be billed once every 30 days. And you can't bill it early, otherwise it won't be reimbursed. So you do kind of have to track the last time you billed it. The way that I do this, and I think it's kind of just fitting into my normal practices, I'm not doing interpretation outside of patient visits. So I will typically go through it with patient at a visit, whether it's face-to-face or telemedicine, and then if they need to follow up in a month because we made a big change, then they'll follow up, and then I'll bill it out that visit too, because you can bill this out on top of your typical LOS code for that visit. And then just for reimbursement sakes, it's 0.7 RVUs, so that will be attributed to you, for productivity incentives, et cetera. This is that job aid right there. You can see that it's only 8 pages, so not too hard to print the whole thing. But if you only want the pertinent parts or the highlights, I would say section 9, which is that billing and coding summary table that I just showed you. And then section 10 is the smart text summary. So if you can remember all those dot phrases. I apologize that the names for the dot phrases are so long, but there are a million dot phrases in Epic, and to be unique, you need to make it long. There are some additional resources. That's the link to the presentation that Savitha put on around how to interpret AGP reports. This is the telemedicine SharePoint site focused on RPM, and it's got all those resources and job aids, including the link to that toolkit that I just showed you. That's the link to the training video from Abbott. That's kind of like a little bit shorter, it's about 13 minutes. And then just for summary, these are all the dot phrases that you could potentially use. Again, in the job aid, there is a kind of little table with all these in it for easy reference. And let's pause for questions. That was a lot, guys, but happy to stick on as long as you need to answer questions.
Thank you. Thank you, Crystal. I wanted to ask, so are you going to send out a link that has everything? Are you going to send out a presentation? Okay.
Yeah, Mika will send that out, all of that out after this.
Perfect. That's great. Thank you. And then also just a reminder, we're also in the pilot for the Medicare Medicaid patients. So you could do the referral to diabetes education if they're Medicare Medicaid and they're over 9. We have kind of that donation from a donor that we're in the pilot for, and Deb will contact the patient and put the CGM on those patients. And I think we've done 3, or we have about.
There's more than that. I just did one today, and I have some more coming in. So I've got some tomorrow, and it's abundant.
Oh, yay. Okay, excellent. So thank you. So this will be a nice they'll kind of complement each other. So this is great. Thank you for the tools. I think having some phrases and tools in place is excellent.
Yeah, maybe one FAQ, one question that's come up every time I've done training. So what about patients with impaired glucose tolerance? Because I think we all can get like itchy fingers. So it's not FDA approved. You can't get coverage, even commercial won't cover it. You have a lot of, you know, obviously professional flexibility, but Deb's not going to support that program. So they're not enrolled in this program, but people get asked. I think Savita actually addressed that in the lightning rounds, that there's not really a lot of good evidence, but you know, you're going to get asked that. So have your answer ready.
Okay.
Other questions?
Really
about this
kind of
program?
an abuse of a really fine tool, actually. So
Okay.
Yeah, Savita in the presentation, she mentioned that there are like lifestyle websites that are prescribing it, even people who don't have IGT, you know, who just want all their metrics to look great and are using it. So, you know, again, you guys have a pretty digitally savvy population. I wouldn't be surprised if you guys already got questions about this. Also, Abbott and Dexcom, they're really marketing the heck out of these things. So, you know, it's really out there. So. All right. Well, thanks, guys. If you have other questions, please let us know. Pam, you know, if people have medical questions or clinical things, please direct to me. If it's technical, like I can't find the dot phrases, something funky's happening with the referrals, let Mika know. He's kind of been liaisoning with the IT team on things. So,
so it's already been shared with everybody, like in primary care.
Yeah.